Okay, everybody, we're gonna, be mindful of everybody's time, so we're gonna go ahead and get started as more people seem to be hopping on here. But we got another full session. We've got a didactic presentation from Paula Reimer, and then we have a case presentation from Suzanne Clemens. And then also, I just want to take a minute. I know we canceled the previous session that was on March 15th. That's now rescheduled for April 26th. Okay, same time. We're going to use the same link. I will make sure that that's in all the recap and upcoming emails, just so we are aware, because that is a change to the schedule. And if you are having issues with your Zoom, you shouldn't. It should be fine. Please don't hesitate to reach out and let me know. We'll get that rectified, but we are rescheduling that to the 26th of April. So please let me know if you have any questions. For those who have just joined, it looks like people are seeing, what to do and are getting in the habit, but please use the chat to introduce yourself throughout the session. We'll make sure those are logged for attendance and CE purposes. But we are going to go ahead and get started. We're going to start with the didactic presentation. So Paula, give me a minute. I will pull up your slides and I will give you the go ahead to start your presentation. So give me 1 second.
Okay.
All right, go ahead. The floor is yours.
Okay. Hello, everyone. And so grateful to be a part of this Project Echo. And I'm glad that you're all on with us today. What we're looking at basically is what we did here at Marshall University. We did a particular program looking at Stop Suicide. And this is basically looking at what you can incorporate into your higher learning institution, what would work for you guys, what would be some specifics that you might want to include. But we received a GLS grant in 2018, fall of 2018, to 2021. And so this was developed, what we did was developed out of the GLS grant, which is the Garrett Lee Smith Suicide Prevention grant for campus. And I'm just kind of going to go through what all we kind of incorporated with the funding that we received. Our first piece that we did, if you want to advance the slides, Jay, is was kindness calls. And Dr. Candace Lane, our counseling center director, who really, we worked very closely together, and she was wonderful to work with. I couldn't ask for a better person. And she and Michelle Biggs, and Michelle was just as helpful and wonderful, but we worked on a piece that was called Kindness Calls. We changed the name. Dr. Lane had went to a seminar at a high state university and come back and said, maybe we could do something similar to what they did. And so we kind of made this our own. We based this on Dr. Thomas Joyner's interpersonal theory of suicide. Now, this come out of a need because when COVID happened, our students were so isolated, and a lot of them stayed on campus. They had to do different, everything differently, and everyone knows. But this was a point of contact for our students. The lack of being connected on campus during the intensity part of COVID was very scary. And our students, voiced that, that they were not feeling like that they were a part of campus, that campus experience was slipping by them. And so we based this out of this particular theory that Dr. Joyner had created on suicide prevention, and that felt belongingness and perceived burdensomeness and acquired ability. So we kind of looked at these pieces and looked intently of what we could do to help people feel like they still belonged and that they were not a burden, that we didn't have to check on them, but we wanted to check on them and see how that they basically were doing and how we could help and what we could do to help create some more connected pieces. Okay, next slide. So not only did we want the students to feel connected, but we wanted to feel connected. We didn't want to work in silos. Across campus, we worked with all different partnerships that we had created to make the students feel safe and to share that load that, that they were feeling, with not being able to connect as much. And so with the development of that, we looked at what was our needs, and this was from the beginning of the GLS grant. What was our needs on the university? How do we get students to connect with the counseling center or mental health helps, resources that we had on campus, our food pantry, medical, how to just to get them to reach out and utilize resources. So we looked at different departments. We pulled them in as council members and agencies. We had a BIT council that was already in place. We had several others. And so we incorporated them in to also into our GLS grant and, how to, to connect our students. And we worked with outside agencies to construct partnerships that were very useful, and communication skills with students, like, who they come in contact with the most and who would be able to influence them to reach out. Because a lot of our students would say, well, I didn't know I could do that, or I didn't know that that was available to me. So we worked very heavily with housing. And we trained them in QPR. We trained them in mental health first aid, safe talk. Different students or different groups took different trainings. And these are all evidence-based trainings that showed us that we could actually use the best resources that we had available. So if you want to go to the next slide, that'll be good. Okay, so our advisory council was our major partners. Our major partner on campus was Counseling Center, Student Affairs, College of Health Professions, Behavioral Health Center was started right prior to COVID. Our social work department, our nursing department, public health department, psych department, all these were partners on this. And so what they brought to the table was ways for us to stop suicide, ways for us to treat mental health issues with our students. We created what we call, this partnership, but it was a safety net for positive mental health and wellness across campus. We were very, very present. Students seen us before COVID. We had Walk for Hope, which we had people to speak, and we made it more of a festive occasion. So with this, we were just being what we call community minded on campus, that everybody was a part of this community and that we had to look at each piece. So if you want to advance the slide and see if that little 4-minute video will work, Jay, it might.
Let me see if I can copy the link. Let me stop share and see if I can copy the link over into YouTube. Give me 1 second.
Okay. But this little video talks about Circles for Hope, and it's actually showing a community, but we kind of reflected and looked whenever writing this grant, that we would make this like a community effort on campus, and the entire campus was part of that, and that we made everything a safety net. Everything that we were doing, we would reach out to all members, all departments for training, provide training for these groups that would actually attend it. Our biggest training that we did that really got a lot of response was QPR. And that's because it's an hour and it's interactive. We do a role play and teach students actually how to reach out to their friends, what to say. And then once the question of, are you feeling suicidal? Are you in crisis? Asking these questions, then persuading them to say, hey, let me walk with you to the counseling center. Let's call someone at the counseling center. Our counselors take on call after hours. And so we were able to connect them in that manner as well. And we taught our students as best that we could, what all the resources were on campus and who to call whenever you had a friend that was actually in a crisis. Okay.
So I think I have it here, Paula. I can share share the video here real quick.
Okay. It's like a little cartoon type video. It's real short.
Yeah. Sure. And everybody just let me know if you can't hear it. That's the one thing. Let's see if it works.
We are living in a time when suicide is a chronic and an escalating concern. Recent studies have revealed that not only has suicide become one of the leading causes of injury death in America, but also one of the leading causes of death for people between the ages of 15 and 49, surpassing even cancer. Can most suicides be prevented? The answer is yes. Individuals who are contemplating suicide frequently give warning signs of their distress. Circles for Hope uses a comprehensive, holistic, and grassroots approach to community suicide prevention, intervention, and postvention. An African proverb says, "It takes an entire village to raise a child." Hope for Utah believes it takes an entire community to save one. Circles for Hope builds community connections by training adults to take an active role in suicide prevention. Community trainings are provided to understand warning signs and who is at risk, how to intervene, and where to go for help. Circles for Hope also creates essential partnerships with the local mental health agency, as irreplaceable resources are provided throughout the community. They are a critical part of a community crisis team, as people from all agencies work together and share information for the public good. Circles for Hope offers school programs and training for staff in suicide prevention, intervention, and postvention. Successful suicide prevention begins with education, and prevention is where the greatest energy should be focused. The goal is to train all school personnel to recognize warning signs, identify someone who needs help, where to access the help, and when to notify family. The schools also implement a peer-to-peer Hope Squad program, where students are nominated to become trained in suicide prevention. The impact of suicide is far-reaching and affects entire communities. When communities, mental health organizations, and schools work together to prevent suicide, the entire community is strengthened. Working together, there's hope that suicide can be prevented. For more information on suicide prevention, intervention, and postvention, visit hopeforutah.com.
Now, of course, we're not Utah, but they have a good idea here what's with the work they're doing. And that's one reason why I wanted to use that particular piece. Jay, if you want to advance the slide. Now, understanding the 4 circles of hope and how they work together is essential, and use your 4 circles to develop a safety net that is specific to your institution. So what groups would you put, and who would you put in there? I just put our basic pieces in this picture, but when you think about, of course, your students are at the center of this, but looking at school programs, what kind of programs could you incorporate, to work with the students to make everything kind of collaborate, that safety net that would develop that? And, what kind of data would you look for and use for to create these practical safety nets? So our partnerships was key. And like I've explained to you, the different ones before, like our counseling center, our student affairs, our behavioral health center that was developed out of the social work department here, the nursing program, public health department. So we use those partnerships. Our counseling department, that was our educational counseling department, plus psych. They brought in their students that was working on their doctorate in psychology. And so they were also very helpful. Our campus connections that were outside, which was our community mental health, which was Prestera. And then we looked at different, we had pastors, chaplains, different people that were also on our counseling board for that spiritual component for students that preferred that. We had a lot of different pieces, like with our rec center and with our exercise and nutrition departments within the COHP. So these will all come together as part of our safety net for our students. Now, what might work for us may not work at another school. So I want you to remember that this is very specific to your institution. Who do you think would want to be your partner? Who do you think that would want to work with you? The trainings that we did, of course, is the question, persuade, refer, the QPR, which is an hour long that students really engaged in. We had numerous professors have us come to their classes. We trained our Greek life, our different groups there, sports groups. Coach Huff, our football coach here, has been very engaged in this. Our swim teams, our tennis, just numerous coaches that has really come on board with this. Our soccer team. So they've all engaged with this particular piece. We had the virtual start from Living Works, which trained faculty and staff, and like our RAs, our RGs. So I think there was about 120 some students on campus that actually took the START training, besides staff and faculty. Then we had what we call TFCBT, and that was for our graduate students, psych, nursing, social work, any clinical mental health. We had approximately 50 to 60 students take that out of our grad school. Our CAMS was what we shared with our community and our grad students, and there was approximately 116 individuals trained in CAMS. Now, our kindness calls were done by graduate students and some undergrad social work students. We made approximately, I'm thinking that the number that has been turned into me so far is 400 students was connected. And of course, we had some that did not answer. We had some that didn't want to participate, but for the majority, probably 70% of the students called they engaged with us in conversation. And so we were able to track, what their needs were. A lot of the needs had to do with resources such as, there was some projects done on campus that looked at food disparities. And so we were able to connect them with the food pantry that the nutrition department, the dietary department actually ran. And so there was several things, transportation to appointments and different things. So we were able to even connect in that way. There were several, I'm thinking like maybe 4 to 5%, but ask if they could have callbacks, that somebody would call them weekly, check on them, have them, and we connected them also with our behavioral health sessions as well. We use Teachable Moments Youth Brief Intervention to train graduate students. We wanted to share this with people at our local hospitals, but so far that we've not been able to provide that at this time. The Zero Suicide Initiative that I was trained in from the Henry Ford healthcare systems, that has been a big piece at a lot of healthcare agencies. We have not been able to share that as well. We're hoping to get that into the grand rounds for our med students, but so far this hasn't taken place, but we're still working on that. Next slide. Comprehensive approach to suicide prevention. We want this to be kind of come into play, like each department kind of take this on, enhancing protective and preventive factors, and helping students to develop some life skills and connectedness, and which COVID presented an opportunity, but also a problem in getting that done. We look at a lot of students that come to us that are first generation. They come to us also from foster care where they've aged out, and we look at that lack of connectiveness and support system. So we've really looked at these pieces, how to break this down and how to help students develop those skills. Early intervention, identifying those at risk and increasing need for help. And so we really worked with our RAs and our resident directors as well. Housing was a big piece of this. And also our counselors and our counseling center, they were able to flag students that were at increased risk and do an early intervention. We made sure that clinical services were available, even though our counseling center was bombarded. They really worked hard. They really increased, their level of service as well, as far as, getting people in, seeing them, assessing them for what level of risk they were at. We were trying on campus, like for environmental safety. And so we reached out to campus security, different people that students see every day, as far as like food service and different ones, offering QPR to them. Now, the next slide is about we were able to use our GLS funds for a phone app. Of course, students love their phone apps and everything. It's called WealthTrack. if you can, Jay, click on that link. I think it's embedded that it should go up. If not, well, we might have to. I just wanted to show you the website, but this
So
WealthTrack
Paula,
app, yeah.
Paul, I'm going to try to pull it up. I just wanted to give you, I'll share it if it comes up correctly.
Okay.
But I'll give you the 2-minute warning here so we can have a discussion. I know you're coming to the end.
Okay, I'm going fast.
Yeah. No, that's okay. I got the website
But-
up. I'll share it as you're talking.
Okay, and this WealthTrack app is something that we use the funds from the GLS grant, that it was free to every student, staff, faculty, administration on Marshall's campus. Anybody with an identifying Marshall number was able to use this. And it's I don't know if that was I don't know why it come up that way. It should have come up to the home page, but it didn't, Jay.
Okay.
But I wanted you to know about this because this also was, we were able to, if a student wanted to, and they had a counselor in the counseling center, they were actually able to embed their mood check or their mood diary in with the counseling center. So the last slide is, we made random calls to students living on campus. Numbers without identification on it were provided by Student Affairs. We had 2 student interns in the counseling center and 2 student assistants in the COHP Behavioral Health Center that made the calls along with myself. We were all was trained in QPR, and we were under supervision. Of course, the students were of a clinician, myself and Dr. Lane. We reported all of our findings into a Qualtrics survey. We asked them if they want to be a part of it before we even recorded any of the answers that they gave us. So this was how we tried to keep students connected and keep them safe. And this is a part of what we did here at Marshall for the last 2.5, 3.5 years. So if you have any questions.
Feel free to raise your hand, unmute, or put them in the chat.
Hi, this is T. Ann from WVU, and I just wanted to just echo what I think lots of people are saying, which is that's a pretty comprehensive sort of, takes a village approach. And yeah, I mean, Paula, I just was very impressed. I hate to say that Marshall's doing anything right because, we don't wear green down here, but it's very impressive. So I just really want to appreciate the work that you're doing. I know that it probably needs to be said, you're doing that work while you're seeing people back to back because your volume has been tremendous. So thank you. And thanks for taking the time to share this.
One thing, like you said, y'all don't wear green down there, but I don't wear blue or navy and gold or green. I'm a royal blue from UK. So it's kind of a different setting, but I'm glad that Marshall has adopted me and took me in the fold up here. But one of those things that I felt like that I did learn as being suicide prevention coordinator at UK for a short time was that it takes everybody to keep kids safe, and that's our goal, regardless of what department gets the credit or what department does this work or that work. We just wanted to keep kids safe. I don't know, I'll be real quick here, but I know that some of you know my story, but I lost a daughter to suicide when she was in college. And so that's really one reason why this is my passion. It's been almost 19 years ago, but, it really devastated EKU, and it really, her coaches, she was track, soccer and academic scholarships. And it was really devastating to them. And I realized then, you know, how many people it does affect. And, you know, it's something you want to prevent at all, you know, in every way that you can do it. You know, you want to prevent a suicide loss on campus or anywhere for that matter.
Paula, we have a question in the chat. It's asking, could you give a few more details on the kindness calls? Did you phrase the call as a check-in?
We kind of phrased it, and I can even send questions, what questions we ask, if you want. But we phrased it as a hello call. We're, you know, calling just to see how everybody's doing because of COVID-19. And we kind of placed it on, you know, on that particular piece, you know, like we know that you're not getting to do all the things that you were doing, and we want to check on and see how you're doing and if there's anything you need. And it was just kind of like, we're all in this together. That was kind of how we phrased the hello part. You know, we were blaming COVID. We didn't want to say we're checking on you. You know, we want to see how you're doing mentally, but we didn't phrase it that way. So
we've got another one in the chat asking for non-clinical people on the call who may not be as familiar. Can you talk a little more about what it means reduction looks like for campuses? What means reductions?
Well, that part is probably one of the hardest pieces, but what we did, we had a class that we started right before COVID kind of shut us down, was a suicidology class. And we talked about means restriction. Everybody that was in the housing, the suicidology class, different groups took what we call CALM training. You can go to sprc.org and take CALM training. It's a means restriction or a means reduction training. I think I can probably type that in for you.
As Paula is doing it, there's been some other links in by Carolyn about the grant. So we'll make sure those are in the recap, but they are also in the chat.
Also, we are presently writing for another GLS grant. They're allowing people that have had it before to reapply. And we are looking for some small schools that don't know if they can, it's a match grant. So that causes a lot of extra work and concern because you have to get partners to match with you. So if there are people like in the counseling centers or different departments or maybe in advising that would want to be a part of what we're writing right now, you know, the small school part, because we're doing that as our community, from campus to community section on our grant. So if you would be interested, I'm going to be wrapping up the writing of this one probably by next Monday. So if you'd want to give me a shout out, we definitely, thanks Carolyn, and would definitely want to include you because we could provide those trainings for your campus, for your folks by Zoom, you know, at no charge, and that way you would be able to be a part of that as well.
Okay, last call for questions. We'll take one more question if there's one, and then we'll move to the case presentation. Okay, hearing none, we will move to the case. Paula, thank you so much for the presentation and sharing your story. Real powerful stuff. We appreciate it.
Thank you, Jay.
Okay. All right, let's see, Susan, I will pull up the case and I'll throw it to you.
All righty, sounds good. Paula, wonderful work. Thank you for sharing
you.
that. That's spectacular.
Thank you.
So.
Go for it, go ahead. Yep.
Go ahead, Jay.
No, I was gonna say, I was throwing it to you. Go for it.
Oh, okay, fine. So basically, this is a case that I am seeing right now. I've been with this person. It'll be next month will be a year. I'm a community college director. I'm a clinical psychologist. And so most of our students will be with us just 2 years, not 4 years. And of course, we don't have any dorms or anything like that. So our students are kind of predominantly non-traditional. This particular person came to me originally as my office also handles disability services. So she came in for disability services her first semester. And the next spring, she showed up for counseling. She basically came in and said that she needed to talk. She thought she needed to talk to someone. Her originally presented problems were increased depressive symptoms, bulimia, and she was cutting, but it wasn't working for her now. We know what that means, right? So that's a big red flag. She's female, age 20, very attractive, a little bit overweight, but not obese. She's doing well with her classes, and she had a job, and she was doing well with her job. She currently was living at home with her parents and a younger sibling. She didn't have any, she did have some friends, so she had a support system, no current romantic interest. And in relation to the cognitive presentation here, she was somewhat intuitive, but not a lot. She presented with low self-esteem. She would totally say, I'm not smart. I can't do this, even though she was doing well with the classes. So there was a little cognitive dissonance in there. When I would ask her questions, she would frequently answer, I don't know, when I was asking about her thoughts or her feelings. And sometimes I was not sure, did not know, or was she just didn't want to think about this? Looking for that kind of stuff. And I think that was probably both based on the content of the questions I was asking. She was previously diagnosed, and let me finish at the back of the history. She was raised rural, and she came from a family that was extremely conservatively Christian. There was a history of physical abuse by a father. She had also been bullied and sexually assaulted when she was in middle school by a female. She made notes here so I couldn't forget everything. She was in an abusive relationship with a male in high school and had also been sexually assaulted by another male. Her training from her mom was pretty much when dad was being abusive, just take it. That kind of stuff. She had previous diagnoses. I got them in here somewhere here. Of anorexia nervosa. She didn't have any current symptoms that moved into the binge eating disorder. She was also diagnosed with a conversion disorder, but she did not know what symptoms she was having, and I didn't see anything for that type of stuff. She was also diagnosed with major depressive disorder, generalized anxiety disorder, bipolar. There is a difference of opinion between a previous counselor and her psychiatrist as bipolar 1 or 2. The psychiatrist went for 1 or 2, the counselor went for 1. And she was chronically suicidal with 1 episode of inpatient. By her report, she has been on psychotropic medication since she was about 14 years old. I went into the trauma aspect of this, childhood trauma, if you want to get into the complex trauma on that kind of stuff. And she did present at least twice hypomanic, at least, if not manic. So she did present with that point at the most part. I would like this to be interactive. Does anyone have any questions or comments so far? I can't see that. Was borderline
Yeah, we
personality?
have one. Yeah.
Was borderline personality explored? I had thought about that, but that was never, diagnosis was not previously given to her. It's good comment, good comment. Okay, so moving into kind of the training, I am an integrated psychologist. My main
Susan, can I interrupt you for a second? I'm sorry.
Oh, absolutely. Go ahead.
This is T. Ann from WVU.
Uh-huh.
I'm wondering about the acuteness of her suicidality, what that looked like, because that could derail any treatment, really.
Yes, absolutely. And that was difficult for us. I was going to talk a little bit about that. She had a couple of incidences of that. And some of the treatment that I did with her in relation to that was, I'm the only counselor. And I'm sure the rest of you guys are, I can see people shaking their heads with this. So I will sometimes I monitor my emails for people in the evenings and weekends and holidays and everything like that. And so there was one episode that she needed to be hospitalized. So she and I, we were meeting, and that became evident. So we arranged that. Her mother took her to the hospital, and apparently there were no beds available, and so they discharged her. I don't know, Tian, is that kind of where you wanted to go? What more information?
Yeah, I wonder if when she's coming to sessions, is her suicidality still heightened? Is she still presenting with an active plan?
Very good question on that one. So in relation to the treatments with that one, when I do that, I actually use I have an intake that I use with this. I use the suicidal adult assessment protocol with that one. And then when she first presented with that, one of the first things that we did was to come up with a safety plan. And even though, we know that those are not always the best thing, but that's what we had. We created a weekly monitoring of symptoms on that. We used the BDI-2 for that one, the Beck's hopelessness scale, and the Beck scale for suicidal ideation. And within the first, let's say she started with us, me in the end of April, and she, by the end of June, her BDI for depression tended to be moderate and kind of stays there for the part. Hopelessness went down significantly, and then the suicidal ideation by the end of June went down to 0. So does that answer the question, Tian?
It does, thank you.
Okay. So basically our plan at the beginning was to decrease her depression, her hopelessness, and all that kind of stuff. And we used CBT, obviously, acceptance and commitment therapy. I used some interpersonal therapy with that. We were treating anxiety and depression with psychoeducation, working with core beliefs, that kind of stuff. She found out how important it is for her to have regular interactions with her friends, and that was kind of interesting for her. She really connected with thinking about the eating disorders in her history. There was a lot of connection she had with acceptance and commitment therapy of acceptance and diffusion from your thoughts. And that came in probably a couple of months ago. She really connected with that to some extent. So right now she's kind of stabilized on this kind of stuff. She was very interested she found a book on intuitive eating. Has anybody seen that book? She was very interested in that concept, and we talked about that a little bit, and she didn't want to work with it. She tends to be not compliant with medications and treatments, and I think that's why we had the 2 episodes of hypomania. on that one, and the depression, and she has come into the realization that she really needs to take her meds. She kind of played around with it a little bit at one point where she said, I've been on meds since I was 14 years old. I want to see if I really need to have them. Yeah, and that one, we had a little crisis on that one. On that one. So we tend to use a SUDS unit on a regular basis to monitor her depression and her suicidality. And the newest thing that just came up in the past few weeks is that I've always felt that there was something that she wasn't opening up to me with, and she did. And it was when she opened up to something like that, I think everything's going to be a little bit better. But when you think about this, we have them for 2 years. If they don't come to us right at the beginning, how many people, if you have someone with a history like this, how can you treat them like this? She doesn't want to go other places. She, many of our people, we have non-traditional students for the most part. Many of them don't even have insurance. They're working, they don't have enough money to buy insurance, and they don't qualify for Medicaid without paying for it. I mean, so guys, tell us, how do we do this?
Thank you, Susan. We'll open it up to everybody. Thank you for the presentation. Feel free to use the chat just like we were, or just unmute or raise your hand. Who would like to start us off?
So no thoughts at all, huh? Come on, guys, thanks.
I'll just say, to echo Susan's, finding, we are the only ones for a lot of people. And in our area, even if they have insurance, getting an appointment with someone in the community is months. And I run across this frequently, particularly with graduating folks. I've got an emergent situation right now that this person tried to get seen at home during spring break, and they were told June.
Yeah.
Carolyn, would you mind unmuting and asking your questions? You put your questions in the chat, but maybe you can just.
Yeah, Susan, it sounds like you're providing a high level of service to the student. And I'm just curious, being that you're on a 2-year campus, are there other resources other than the accommodations and the counseling that are able to help the student along? Do you feel like with those limited supports that she can function within her classes, or are there other things that faculty or staff could be doing to help support these students?
Those are really good questions, Carolyn, and it's like we train our people in QPR. We're getting ready to do the mental health first aid training. We're small campus, small faculty. Many of our faculty are adjuncts, and they're not required to take any trainings. So we don't necessarily can hit some of the faculty. I always I've been here, this is my 8th year, and the faculty are my front lines. If the faculty are the ones that connect them with us, with me. And we just don't have the resources to do all that personnel wise, I would love to be able to do some of the things that we're doing here. We try to do some reach out for things. Our students tend to work, have families, and they don't come to events. Even if we have lunch and learning, give them food. You always say, oh, students will come to get food. No, they don't. Some of our programs are run from 8 o'clock in the morning until 5 o'clock at night, and they got 1 hour for lunch, and they don't want to be on campus. They get in the car and go to McDonald's. They don't come to events. Anybody has any ideas, just let me have it.
Oh, Kurt, we're having the same issue as yesterday. Sorry, yeah. Sure what's going on there. Please put it in the chat though, Kurt. We'll make sure to get that answered.
That was kind of weird to sound.
It happened twice. Yeah, it's happened before, unfortunately. Yeah.
Yeah, yeah.
Yeah, Susan, I just wanted to chime in. I mean, as someone who's also at a community and technical college, yeah, I mean, what you're saying really resonates with me too. And we were having a discussion in a meeting just this morning of one of those programs that's 8 to 5. And yeah, you're not getting their attention between 12 and 1 because they want to get a break and get outside, see some sunlight, that sort of thing. But yeah, I've seen the same thing. We actually don't have a counselor right now. But we have had a few cases in the last year of students with suicidal ideation, and the faculty, I'm happy to say, have really stepped up and handled those well. But of course, like you said, it's that issue of making sure that your faculty, have the right tools to be able to at least do a basic intervention there. But yeah, it sounds like you're doing well with what you've got.
Oh, well, thank you. It's just as the frustration, it goes back to, don't even get me started on the mental health issues in the United States and in West Virginia. I mean, the fact that my student went to the ER and was discharged. I mean, it was just like, what do you do?
Kurt, I see you popped back up. Do you want to try again?
Let's try again. Is this better? All right. Super.
Yeah.
Well, what I was going to share, Susan, is that though I can commiserate with your circumstances, we too cannot get anything really going on campus for students, especially since COVID. It's like starting over for trying to get someone to be on campus, making it very difficult. Like yourself, we have limited resources. I do have a good crisis stab unit with Westbrook Health Services, and they've become someone that has been quite an ally for us. But a lot of folks don't have that kind of connection.
Yeah. So I'm just hearing, our common frustration with the whole system, huh?
One of the things that we found, or that I found personally when working on this project from the very beginning, was we have a counseling center. That's what they're for. And, it's got to be everybody. It really does. Because like you said, Suzanne, the front line is our faculty, and they see, differences. They see changes in students, and, having them to know mental health first aid is huge. So they can at least pick up on those risk factors, looking at, that behavior change. And it sounds to me like you're doing a very good job.
Well, thank you.
With all that you incorporated into her treatment. I mean, it's frustrating when you go to an ED and they don't keep them for very long. And it is extremely frustrating.
Any other comments or advice? Anything
Yeah,
like
I
that?
would like to make
Jerry.
a comment. Terry Crowley Woods, and I'm here in the Eastern Panhandle, and I was wondering, Susan, if you have a hospice organization in your area.
Good question. It's kind of interesting because I'm from Morgantown, and actually the campus that I am on right now, we have several campuses, and the one that I'm on is in Marion County, and I'm not really familiar with them having a hospice here. I know that Morgantown does, but that's interesting.
Well, the reason I ask is my husband worked at our hospice of the Eastern Panhandle, and they did have a community component and ran suicide, support groups. So I guess it's not all of the hospices have that kind of arm of their intervention, but it may be worth a try. I wanted to offer something, and I know that it's suffering for everyone. So thank you.
That's a great idea. Thank you. Again, getting back into the community aspect of the whole thing. Yeah, with the circles there, Paula.
And we have seen, I've utilized hospice support groups as well, because they do the postvention piece, which is a big, people that have experienced suicide loss or have been exposed to that, even as a survivor, a lived experience. Postvention is intricate. I mean, it is essential to someone that is chronically suicidal. That's a very, very good idea, Jerry. I completely forgot about that. That they are key in that area, that they do a lot of work in postvention.
Great, that's a great idea. Thank you. I'm going to try to asterisk that one.
Yeah, I don't have any results to comment on yet, but a little shout out to HEPC's mental health grant. We're using money in the current cycle. Since we don't have mental health professionals, I'm using that to train one of our educational counselors at each campus to be a certified QPR gatekeeper instructor, just so I then have somebody at each campus that can be doing those trainings, whether it's the students or employees or staff or faculty, and that'll be good for 3 years. And then after that, the recertification price is fairly affordable. I think we can do that. So that's just sort of my way of trying to maybe spread sort of a network that way. And again, that's probably really basic for what a lot of the schools are doing. But for us, I think that'll be a step up and a way to try to get more knowledge out there about how to interact and refer and all those sorts of things.
Yeah, we use some of the mental health grant that I got. Thank you, Carolyn. To train a second, because I do QPR, a second QPR trainer, and she will be doing her first training with students next week, actually.
That's great. Carolyn, speaking of Carolyn, dropped a couple of things in the chat. One is suicide support groups in West Virginia, so link to that. So make sure to get that out of the chat, and we'll put it in the recap. And then also the Depression and Bipolar Support Alliance.
Yeah.
They're looks like they're targeting campus and peers, so contact information in there as well. So thank you, Carolyn. Those. We have, looks like 2 minutes left. Does anybody want to have any final comments here before we wrap up? Susan, thank you very much. Very complex case, but you're really, I mean, from a lay person who has no experience with this, fantastic job doing as much as you can with what you have. And I think that's what everybody is saying as well on the call. So kudos to you.
Thank you. That's helpful, because sometimes when I'm doing it, it's like,
yeah. No, I appreciate your time as well as Paula's time with the didactic. Thank you again. Just as a reminder, we'll meet here in 2 weeks on the 12th. And that one's going to be around substance use disorder in college populations. So be sure to tune in for that. And then again, we will meet then the following 2 weeks on April 26th as the makeup session for the March 15th session that got canceled. So you'll be getting announcements for it, so don't worry about forgetting it. You're going to hate me by the time we're done with this because of all the emails I've sent you, but that's what I'm here for. So if there aren't any other questions or comments, we'll call it a session and we'll meet again in 2 weeks. All right, everybody, take care. Have a good rest of the week.